Good afternoon, everybody, and welcome to the afternoon session. Our first speaker is Dr. Nazeer Mohamed. Dr. Mohamed is a physician and endocrinologist at Chris Hani Baragwanath Academic Hospital and a lecturer at the University of the Witwatersrand. He is involved in both undergrad and postgraduate teaching and is a past chairperson of SEMSA. He has contributed to national and international diabetes and thyroid guidelines. Dr. Mohamed has an interest in critical care with emphasis on metabolic emergencies. But today he is taking it from the intensive care unit right back to the patient at home and educating us on the importance of self-monitoring of blood glucose in patients with diabetes. Thank you.
Thank you, Dr. van der Westhuizen, for that kind introduction. And thank you to the organizers for the invitation to speak at this meeting. I just want to check, are my slides visible?
All good, Dr. Mohamed, thank you.
Okay, thank you. Okay, so I've been asked to speak about the importance of self-monitoring of blood glucose in people with diabetes. And often it seems like a very simple topic, but I think a very neglected area. So before we proceed, just to get the disclaimer that this talk has been sponsored by Roche. So the questions that we try to answer is glycemic control still of importance in 2023? And the reason that often comes up is we're bombarded by cardiovascular risk reduction. We shouldn't be using the old drugs. We should only be worrying about cardiovascular outcome trials. And we sometimes tend to forget the role of glycemic control. What's the role of the HbA1c? Do I really need to prick myself every day and multiple times a day? And we're now entering the era where technology is really taking off. So is continuous glucose monitoring the new standard of care? For most of this talk, I'll be concentrating on patients with type 2 diabetes, as those are the bulk of patients that are actually seen in GP practice and in the primary healthcare environment. So I don't think I need to really remind this audience that the burden of diabetes, although we often tend to not pay as much attention to it as we do some of the more glamorous conditions, affects a significant proportion of the world. And if this was a stock and you had invested in it and you had a stock that performed the way diabetes numbers are increasing, you'd probably be retired years ago. So we now have 537 million adults living with diabetes, of which almost half of them are undiagnosed. And we often tended to think of diabetes as a disease of the first world, of affluent people. But as you can see, that in the low and middle income countries, the numbers are actually increasing significantly. And it's estimated that those numbers will far exceed the developed world in time to come. Unfortunately, these areas also have the challenge of having suboptimal infrastructure to deal with this pandemic. At the moment, it's thought that about 12% of worldwide deaths are actually attributable to diabetes. And the majority of these patients will die of a cardiovascular death. Having said that, it's still the leading cause of kidney failure, non-traumatic lower limb amputations, blindness in adults. And we also know that approximately 1 person will die every 6 seconds from diabetes. Now, just a little bit of physiology to remind us is that diabetes extends across a continuum. So initially what happens is we have insulin resistance, which goes up, and in response to that insulin resistance, your body starts to make more insulin. So you initially have high insulin levels, but once we get to approximately 10 years, we start to see that the insulin levels start to drop, and concurrently, those patients often require insulin. And this is one of the challenges when we give a talk about diabetes or when we think about diabetes, is one size doesn't fit all. If we had to take 3 patients, we had one diagnosed sort of soon after the onset of disease, another at about 5 years, and a third patient who's now 12 to 15 years down the line. Our approach could definitely not be the same for all of those. And when it comes to monitoring, as well as the glycemic therapies that we would offer these patients, these would also change accordingly. So in terms of how important is the glucose, so what we do know from the UK PDS data, which was one of the only large studies that looked at patients with newly diagnosed diabetes. Most of the other studies that looked at intensive glucose lowering looked at patients who had had diabetes for already 10 years. But what we know is that if we control the glucose, that for every 1% reduction in HbA1c, we reduce the risk of death by 21%, heart attacks by 14%, microvascular complications by 37%, and peripheral vascular disorders by 43%. Another way of looking at it is, we know that for every percentage increase in your HbA1c, there's a greater risk of macrovascular disease. And if we can, at the outset, prevent our patients from actually getting to the HbA1cs of 9 and 10, we'll probably significantly reduce their burden of disease down the line. Now, often we look at the algorithms as to how to manage patients with diabetes, and many doctors often tell me that they're overwhelmed. There are just so many options, we're not really sure what to do. This was the 2017 SAMHSA algorithm, which looked at patients who were stable, who weren't in a hyperglycemic emergency or who had established cardiovascular disease, and there was a stepwise progression. And I draw your attention to the bottom right-hand corner, where it says that you shouldn't use a certain drug if you could achieve the HbA1c. So again, we looked at the HbA1c as being the basis by which we introduce therapies. So that paradigm has changed. And unfortunately, the newest SAMHSA guidelines haven't been published as yet, but hopefully will be published early in the new year. But if we take the new paradigm, we then categorize our patients as to whether they have established cardiovascular disease, heart failure, chronic kidney disease, and those patients then require certain therapies, such as an SGLT2 inhibitors and perhaps a GLP-1 receptor agonist. In the absence of those, then glycemic management still takes the main emphasis of therapy. And again, with the increased number of drugs that are available, it often becomes very confusing. Now, once again, in terms of escalating to different therapies, we still utilize the HbA1c as our modality. Just one quick slide. It's just to remember that HbA1c or glycemic management is only one component of comprehensive care. And the basis of all of this is lifestyle modification and diabetes education. The reason I bring this up is that that part of diabetes is often forgotten. And for the patient who actually is able to modify their diabetes or their lifestyle very early, they have the ability to actually induce remission of their diabetes. Now, we would think that with all these new drugs, we'd be doing really well. And yes, if we look at sort of a 20-year period, we do seem to be gradually getting better in most of the parameters. However, when we look at the composite, so how many patients actually have their lipids, their glucose, and their cholesterol, and their blood pressure at target, we find that that's under 20% of patients. So we still have quite a long way to go. Now, coming back to how do we actually assess glycemic control? And in the same way that our patients with retroviral disease, for example, know their CD4 counts, we should actually get our patients to understand their HbA1c. So we know that the HbA1c is a measurement of the proportion of glycated hemoglobin, and it reflects the average blood glucose between about 3 to 4 months, right? It's usually, in the past, it wasn't as reliable, but currently most laboratories are meant to standardize the HbA1c against a certain standard, and therefore it's fairly reliable. The one practical component is when your patient looks at the HbA1c, we have to just emphasize to them that the HbA1c isn't the average glucose. There is a relationship, but they shouldn't sort of feel that, okay, if the HbA1c says that my HbA1c is 8, that means I'm actually doing well. Because that sort of correlates with an average glucose of about 10. And you see, as we go up, the patient who has an average glucose above 16 often has an HbA1c above 12%. Now, in terms of setting the target, I'm not going to go into this into too much of detail, but we need to individualize our therapy. And what I suggest is when you encounter any patient with diabetes for the first time, you should go through this exercise to see whether is this a low-risk patient, a patient with a low chance of having hypoglycemia, a long life expectancy, are they motivated, do they have resources available? And for that patient, aim for an HbA1c of less than 6.5%. And on the contrary, for that patient who's perhaps, let's say, 85 years old, has significant comorbid diseases, has established cardiovascular disease, we allow an HbA1c perhaps of 7.5 to 8% as being acceptable, because our aim is to avoid hypoglycemia. But what is important is at the outset, establish a target HbA1c with your patient. So they know what the outputs, and then you implement a stepwise adjustment of therapy in that way. But we often see somebody comes in with an HbA1c of 12%, and the doctor says, okay, you know what we'll do is we'll just add a DPP-4 inhibitor, or we'll increase your metformin dose from 850 milligrams twice a day to 1,000 milligrams twice a day. Or if they're on insulin, we say we'll increase by 2 units. Now, I don't think there's anyone that would argue that there's no miraculous property that extra 2 units of insulin that's going to drop an HbA1c of 12% to target. So we then have to sort of work with our patients to see how are we going to meaningfully reduce the HbA1c to the decided target. Although HbA1c is very useful because it, especially in resource-constrained environments where patients may not have access to glucometers, or patients on oral therapies who may not qualify for glucometers, for example, in state practice, the HbA1c gives you an idea of what's happened in the last 3 months. It also allows your patient to not sort of cook the books. So on the day or two before they come to see you, they ensure that they eat very well, they eat healthily, they inject a bit of extra insulin, they come to the clinic with a glucose level of 5, and look, we're doing really well. The HbA1c, usually you see the disconnect with HbA1c sitting at 12% or 10%, and you know that that's a more reliable parameter. Now, unfortunately, HbA1c can be misleading in medical conditions such as anemia, acute inflammation. There are changes with ethnicity and aging. And if you're using a point-of-care device, it may not be as reliable. So you're often looking at the trend. There are still benefits, therefore, of glucose monitoring. So the finger prick, where you'd actually see glycemic excursions, you're able to quantify hypoglycemic events, and you see the dynamic relationship between the insulin, the meals, the carbohydrate content, physical activity, and the resulting glucose levels. And these are important parameters that you can use to educate your patients. Now, we often talk about a triad of glycemic exposure. So the one is the HbA1c, but the other two components are the fasting plasma glucose. And often your patient will come to your rooms and they'll religiously document their fasting glucose every morning. And they'll show it to you with pride. Look, doctor, my glucose levels never go above 7 or 8. And yet the HbA1c comes back markedly elevated. And I often tell the patients that what you're really doing is you're showing me your best glucose of the day. Because that's after being in a fasted state, often it does settle. And if they're on some therapy, it's usually enough to bring it back down. However, the same patient then goes and eats a high carbohydrate breakfast, lunch, and supper, and the excursions are often in the 20s, but they are blissfully unaware that they're actually having the significant postprandial hyperglycemia. The concern for that is postprandial hyperglycemia and glycemic variability are correlated with cardiovascular risk, oxidative stress, and cognitive dysfunction, particularly in the elderly. So when we discuss self-monitoring of blood glucose with our patients, it's important that we sort of engage with them and try and get the patient to understand the rationale behind self-monitoring of blood glucose. So they need to understand the actual steps to perform successful blood glucose monitoring. We need to have an agreement on what's the appropriate time for undertaking the glucose. Because if they do it randomly, it's very difficult for you as a practitioner to see patterns. You know, for that patient who someday takes a glucose level 30 minutes after eating, another day 2 hours, another day 4 hours, it's very difficult to adjust therapy. Agree on the appropriate frequency for undertaking self-monitoring of the glucose, and then understand the cause of the achieved result. So if they have a hypoglycemic episode, ask them to introspect what could have resulted in this. Did they delay a meal? Did they miss a meal? Did they increase their insulin inappropriately? Or were they at a restaurant? And if you can identify a trigger, then often it becomes a learning point for that patient. You also get them to understand the consequences of the achieved result. That, you know, if you're having these repeated highs, it's not enough that you document the highs. What are we going to do to improve the outcomes? So often we say that we tell patients not to waste their blood, that there's no point testing daily and doing nothing about it. This is the one slide I'm going to use relating to the type 1 environment. And what we can see in the type 1 environment is that the more times the patient tests per day, the greater the likelihood that they will achieve an HbA1c at target. So if you have a patient who's testing under twice a day, and these are patients who are on multiple daily doses of insulin, it's not surprising that you almost never will have an HbA1c below 8.5%, irrespective of their age. And yes, for many patients, doing finger prick testing 11, 12 times a day is not really sustainable, they don't really enjoy it, and they sometimes give up. Your patient's much more likely to give up testing if they see nothing coming out of it. So if they're testing, recording the highs, and they have this feeling of helplessness, that patient is very unlikely to continue because they see the repeated monitoring as just documentation of their failure to be, in inverted commas, good diabetics, which is often, the language that we use when we see patients with diabetes. Say, well, you've been good or you've been bad. And that value judgment often takes them away from actually monitoring as they should. So if we go to the SAMHSA guidelines and we say what recommendations should we make for patients and how frequently should they be testing, the recommendation is that patients who are using insulin should be testing perhaps 2 to 4 times a day. Who are injecting 2 to 4 times a day should be testing at least 3 times a day. Now, if for that patient who's taking only basal insulin with oral hypoglycemic agents, the repeated test during the course of the day doesn't really add much more because they can't titrate their oral agents. So we want that fasting glucose because that becomes their target against which they titrate the insulin. And the other tests are there more to tell us that will the patient actually require intensification of therapy. So whether the patient does that every day or a few times a week, sometimes after breakfast, sometimes after lunch, and others after supper, so that we get an idea of whether we need to intensify therapy. For patients on oral agents or injectables such as GLP-1 receptor agonists, the patient can't adjust or titrate their therapy according to their readings. So with the exception of sulfonylureas, the main aim is actually to educate the patient in terms of what lifestyle does, and it becomes a warning system for the patient who's spinning out of control. For the patients on sulfonylureas, we often do encourage them to test 2 or 3 times a day, and particularly if they're on the older sulfonylureas such as glibenclamide or glimepiride, as these have a higher hypoglycemic risk. For those patients, we often tell them test. For the other patients, test maybe 3 or 4 times a week. We should also educate our patients that there are certain times where more intensive testing is required, such as during acute illness, periods of poor glycemic control, fasting, frequent hypoglycemia, and pregnancy. And the targets that we ask them depends on the different societies, but SAMHSA takes that the fasting should be below less than 7, and the 2-hour postprandial should ideally be less than 11. But for that patient who's trying to achieve an HbA1c of less than 6.5%, we try and target a postprandial glucose level of less than 8. If they're going for less than 7, then we go up to less than 10, and for the others, less than 12. Now, the structured testing is what's really required. And for patients where glucose strips are often a cost issue or a way of sort of compromise is you get them to test at pre-specified times. So for example, in this diagram on Mondays, they test twice a day, but focusing on different meals on the different days. And when they come and see you, you then have an idea of what's happening pre and post breakfast and for the other meals as well. And this allows you to reinforce the behavior changes with regard to their lifestyle choices. Now, I'm not going to go into too much of detail, but we know there are significant barriers from doctors who don't have the time in busy clinics to actually spend time with patients, complexity of regimens that patients may not really understand, or often when we adjust doses, we may adjust it on the script, but don't really communicate those to the patient. One of the greatest needs is actually in-depth education, but I don't think there are many GPs, nurse educators who have the time that we actually require for each patient, as you'd see often in the first world setting. And then obviously the resource and financial restrictions that are there. So what's recommended is that we use an integrated personalized diabetes management approach where there are 6 steps where you first educate the patient, you get them to start monitoring their glucose. You then correlate this usually using technology. So apps such as Diasend or Gluco, MySugarWeight actually tabulates the different times. You then sit with the patient and you review the data and you develop a new treatment plan that's acceptable to the patient, and then you assess the efficacy of that intervention. Just the last few slides are on continuous glucose monitoring, and that's sort of taking the world by storm at the moment, especially in the type 1 arena, but we're now starting to see it in the type 2 area as well. So we divide continuous glucose monitoring into 2 different groups, which are intermittently scanned CGM. So here the patient actually has to scan with a handheld reader or an app on their phone, and that documents the different readings. So that's something like flash glucose monitoring with your Libre system. And then you have the real-time or continuous system, which has a transmitter which continuously streams the glucose data, provides alerts, and sometimes even can interact with your insulin pumps for those patients with type 1 diabetes. And you get reports that look something like this. So the parameters, because you are going to see more and more patients coming with these, so maybe let's just quickly run through it. So we often think that these patients need to be at target all the time. But to achieve an HbA1c at target, you only really need to be at target above around 70% of the time, right? So you're allowed to have a few highs. What we often tell the patients is what we want to avoid are the very highs and the very lows. But what these metrics then are put together to give us a glucose management indicator, which correlates reasonably well with an HbA1c. What we also look at is your glucose variability. The more variable, that means the more unpredictable and the more swings from hyper to hypo. And it tells you often that you now need to sort of engage with your patient to see where are these fluxes. You'll then get a composite profile, which will then give you the average. And you can see in this patient, for example, around lunch and after dinner, you have significant hypoglycemic excursions. And the hypoglycemia seems to take place only in the early hours of the morning. So suggests if this patient was on insulin, you now need to reduce that basal insulin during the night. And then lastly, you then get a day-to-day profile, so you can see certain trends. So sometimes the dysglycemia is actually more because of a weekend. So it's currently now coming into recommendations and guidelines for type 2 diabetes. And generally, intermittently scanned glucose monitoring is what should be offered for the patient on insulin therapy, unless you can actually get real-time glucose monitoring at a similar cost. The NICE guidelines from the UK, which takes cost into consideration, also recommend that intermittently scanned CGM should be used for patients with recurrent or severe hypoglycemia, hypoglycemic unawareness, if they have a condition or disability where they cannot self-monitor their glucose but require others to assist them, or where they would otherwise be monitoring more than 8 times a day, because the cost of strips will also then become prohibitive. For those patients who can afford it, you may consider real-time continuous monitoring. So my take-home points for today is glycemic control remains an essential component of preventing complications of diabetes, especially early in the disease. Educate and encourage patients to know their targets, to know their numbers, and then use self-monitoring of blood glucose as part of an integrated, personalized diabetes management strategy. And for appropriate patients, we now need to consider continuous CGM, such as the Libre system, so intermittently scanned CGM for patients on insulin therapy. And with that, I thank you for your attention.